Almost there. We're setting up, almost there. Oh, nice. Good evening, everyone. Welcome to Medical Mondays with Dr. O. And kindly pardon my voice tonight. Remember we did allergic rhinitis a couple of weeks ago. It is here, so I wouldn't say more than that. But welcome. I'm Toyin Okpesami, family practitioner, HIV specialist, and I treat addictions in Maryland. I host Medical Mondays with Dr. O, and I'm always excited to be here. Tonight, we have one of our very own, Dr. Nelson Aluya, who is one of our pillars in the society, in our societies, actually, across states, is also the president of the Nigerian American Public Affairs Committee, the national president, where I'm the chair for the DMV, Pennsylvania, Delaware, and the regional director from South Carolina to Pennsylvania. So Dr. Aluya and I share a lot, in common, or have several canopies that we share together. So my president, kindly unmute and take this over. And while he's doing that, I'll leave you to complete your introduction. While you're doing that, please get ready for a special birthday today. Okay, go ahead. You're muted. You're still muted.
Yeah, sorry.
There you go.
Okay, well,
Welcome.
good evening, everybody. It's good to be here once again. Like I always say, this is family, and it has become the Medical Monday family. It's good to have everybody on. And when my chair calls me, I pay attention. So when she told me that we needed to do something for this week, I thought, we've been doing Medical Monday for such a long time, but at the same time, there are other intrinsic issues that are happening within the medical field that most people don't talk about. And it's something that affects everybody, whether you're a doctor who's in training, you're a doctor who train people, and you're a provider who take care of people at any point. And I've talked about this a couple of times and giving ground rounds on this in different places. And I just thought it was imperative to bring this to the family so that we be aware of what it is and how to tackle it, and at the same time, also how to help build that emotional intelligence in dealing with um, how you manage your response or your emotions to people's attitudes, effects, or affects, and how to do that gives you the best outcomes in life, especially or primarily how you deal with the healthcare industry, particularly your healthcare provider. Um, so that's what it is. And my topic today is on medical gaslighting. Let me put it up. Can you guys see it? Okay.
Yes.
Yes. So medical gaslighting, empowering the patient, reducing healthcare. Oh, that's healthcare. Healthcare disparity. Don't know why it came out like that. So, empowering the patient, reducing healthcare disparities. Now, we understand that healthcare disparities is a big issue, especially for those of us who are people of color. Um, the U.S. stats show that we're number 25 in healthcare um, outcomes and what do you call it, delivery overall of all industrialized or developed countries. I'll use that word. We're 25 for a number of reasons. A lot of people say it's healthcare disparity, and these disparities come as a result of um, policies that have been put on the ground for a long, long, long time. We know of slavery, we know of Jim Crow and segregation and everything else that's happened to us. And when you look at the United States, people of color far worse than anybody else in almost every indices. Um, 4 times at risk of dying, irrespective of your level of education, social status, or economic status, if you're pregnant here in the United States. Um, 4 to 5 times chances of you ending up on dialysis, 6 times risk of having heart attack and stroke and dying from it, and all the other things that we see. So, but one of the things that's coming into the medical lexicon again is gaslighting, medical gaslighting. It's still new to a lot of people, but the term gaslighting, as we move on, is basically relatively new, uh, but it's long-standing problem in the healthcare industry. When healthcare professionals dismiss the problems and symptoms of patients. According to recent New York article, the problem appears to be especially pronounced in certain populations, including women, people of color, geriatrics, patients, the LGBT, and even people who are disabled. As top 10 patient safety concerns from reports in 2022. Now, what is basically gaslighting? The term gaslighting was actually first introduced into um, the social lexicon way back in 1923, where there's a movie that was made called Gaslighting. And this movie, at that point, I think it was still very still, what do you call it? A still movie where a gentleman lit a gas light, and the wife was complaining and saying things about it, and he's like, "No, you're not. What you see is not true. You must be confused. This is not real. It's not a gas." That's how the whole story, but then metamorphosized into other things, and of course, in modern time, the term you hear it more the millennia use the word gaslighting. So, what are the signs and symptoms of gaslighting? Providers interrupting patients, failing to allow patients to elaborate, and giving off the impression that they are not listening to the patients. A lot of times, I mean, each and every one of us here who live in the United States has had one encounter with a healthcare provider, or a medical provider. And a lot of the time, we go to patients, doctors, and we just say, "Oh, he only spent 15 minutes with me or less, but he didn't even allow me talk. He just came and put his head through the door and like, hey, how are you? You okay? Okay, bye." And then start writing. And then he dismisses me. I have all my concerns and problems. I never could say one word. And he left, you know. Again, it's when providers minimizing or downplaying symptoms. Example, questioning whether there's pain. Um, in the black and black brown community, a lot of the time they downplay the pain that we do have, and we're less likely, I think, 1 to 3%, 2 to 3% chances of not getting pain medication, adequate pain control, as compared to other people. Because you know what, nobody wants to think, or you think you're malingering, or you're just faking it, or you're here seeking drugs. Providers blaming symptoms and mental illness without providing the mental health screening referral. Oh, it's all in your head. It's all in your head. And a lot of people have heard that multiple times, um, where they just thought, oh, it's in your head. It's not real. But whoever is feeling it knows what they feel. And sometimes they may not know how to express these things adequately to the provider. And because of that, they come out I mean, a lot of times again, you have medical terms that they're not familiar with, and because of that, and doctors are always in a hurry most of the time, and it's as if they're not paying attention, and they're just thinking about the next patient or whatever the pressure of what they have to do or how much now I might have to type all of these things that you're saying, and all the burden that comes with, medical practice these days. It's a huge burden for doctors when it comes to practicing, but again, is the beast that we have to deal with. We just have to find ways of dealing with it. Now, moving on, providers refusing to discuss symptoms. Doc, I have a headache. And like, oh, really? Okay, you're here today. Your blood pressure says this, this, this. Doc, I didn't come for my blood pressure. I came because I have a headache for 3 days. I go to bed with a headache. I wake up with a headache. That's an alarm symptom. You go to bed with a headache, wake up with a headache, it's an alarm symptom. I feel dizzy with it, or I feel pain that rests in one side of my arm or whatever. Those are alarm symptoms. If the doctor is not paying attention, that's where people miss stuff. By the time they miss stuff, and that we've heard stories where they're like, oh, I was complaining of this headache for a long time, and they never paid attention, and only to find out I have an aneurysm or I have cancer in my brain. So these things do happen. Again, as providers and patients, one of the key things that we're trying to do here is to give you the perspective of a doctor and also give you a perspective of a patient, what we see, how we see them, and how I, as a patient, have seen things as far as with myself. So that we can truly get a 360 view of what it is when you interact with the healthcare industry. Now, moving on, providers failing to order follow-up tests to rule out or confirm diagnosis. I have a headache here. Don't worry, it's nothing. You haven't slept well, or it's the coffee that you're taking. Take Tylenol. Keep taking the Tylenol, and you keep taking Tylenol, it's not helping. Whereas there's something uh, grossly indolently wrong with you. Or I have a stomach pain. Oh well, maybe it's what you ate last night, and that's why. Do you have a diarrhea? Or and a lot of the time, and I use the word profile. We as doctors profile a lot, and that's based on our training, and that's why we profile so that the common things are the common things that we see first. I always say use the word zebras. You see horses first before you see zebra. So the chances of you seeing a zebra is much less than you see in a horse. So a lot of the time, people come in run the meal, headache, abdominal pain every day, or things that like that, and that's what people see and hear. So because they become accustomed to that, they sometimes downplay your signs and symptoms, even when it's imminent and it's causing you much more distress. But then we'll go on to how to ameliorate and how to handle some of all these things as we move on. Now, moving on, when a provider is rude, condescending, belittling behavior from providers. Again, we do that. And sometimes it's just what would I use? The body language that people give, you exude, those things that come out not appropriate or decent of a provider, and that's why um, people tend to behave the way they behave. However, it's also sometimes providers too, they're human beings, and they read people's attitude as well. Patients when they come in, some patients come with an air of superiority, so it's like, hey, this is my turf. Who's going to fight over this? I have control here. Or some patients come in and like, oh, you know what? I Google this. These are my symptoms. Give me give me antibiotics. And that just pisses off the doctor. Like, are you telling my job? So these are some of the things again that result in issues where sometimes even patients feel they're being gaslit. Now, there's a difference between being gaslit and when there's an what do you call it, a misunderstanding, and we need to understand that as well. Because you come with your symptoms and you come in to see me, and you tell me all of these things, and I say, okay, fine, this is what you have, this is what. In my head, in my mind, I eliminate those things. Again, they're horses, and then try to eliminate what zebras are there, so that I make sure you get the best care. But because I did not order MRI for you, doesn't mean I'm gaslighting you. It's just that we have not come to the terms of understanding. And my role is to make you understand why the MRI is not the thing for you right now. Um, Based on some other stuff. We could say, let's do this first and let's do that first before we move to the next one. But one of the biggest issues that happens again is that because providers seem so rushed all the time, a lot of the time they do not spend the time explaining to patients exactly how things are. And that's why patients often feel they're being gaslit. So at the end of it all, we need to also understand that when there's um, not coming to terms between you and your provider, not understanding um, the terms of it, doesn't mean you are being gaslit. We need to learn to differentiate the difference between that and that and that. So, what's the origin of the problem? Medical gaslighting may sometimes stem from cognitive biases, again, and subconscious errors in thinking that occur when individuals process and interpret information. Again, like I said, um, we do, uh, sorry, okay, yes, so we do have some conscious biases. Remember, doctors are human beings and they make their decisions based on prior exposure and experience that they've had in life. And sometimes they carry those things into medical practice. And as they come in, those things is based on their culture, uh, ethnic or religious persuasions, those things come up. For instance, you have a doctor who's from Nigeria or from Ghana, and they have this strong, attitude and character. And some people are like, oh, he's being obnoxious. He feels he has an air of superiority, especially for Nigerians when they say, oh, Nigeria not the carry last. Those kind of terminologies. But again, most people tend to see them as like, oh, they're being hard, they're being so he's not listening to me. And and they get angry. And sometimes some patients come in, they walk into the room and see you're black. They're just angry initially. Or they see you come in, you have an accent, and they don't want to listen to you because they just shut down. And again, once you bring that out, of course, the provider, his role is to actually play the leading role in this to understand where you're coming from and how to handle it. But not everybody's equipped to do that. So that's why a lot of the time when I do this teaching, I try to teach young doctors at the end of it all, bedside manners still really do matter. And how you carry yourself and interpret patients' attitude, behavior, and body language really does matter as well. But then again, at the end of it all, the buck stops with you. Now, it also comes from cognitive biases and diagnostic errors. That will deal with subsequent as we move on as well. Now, things to consider. Does it cast blame? Does it reinforce stereotype? Because again, we live in a multi-ethnic, multicultural, multi-everything society here in the United States. So a lot of all these things comes from stereotype. A person comes in, he's black, he's skinny, and he has yellow eyes. Oh, sickle cell. That's what we assume from the beginning. But it may not be. It may just be something else that's causing that. Or you have, long thin arms and red eyes, and it seems, oh, he's a drug, what do you call it? He's a drug seeker or whatever, you know. So these are the things that we must begin to pay attention to as well. And even as patients need to begin to pay attention as well, even as you walk into a doctor's office, because hey, he's black, he has an accent. And the next thing, some doctors have heard that. What school did you go to? Did you graduate from the United States or you graduated from Africa? Once you just say that, then you're dumb. You don't know what you're talking about. And they just shut down too. You don't want to listen, and they begin to, come up with those words. And they use words that are pejorative as well. And people feel these things. And even doctors feel them as well. And before you know it, there's an issue of casting as what do you call it, aspersions on individuals, and they have eventual bad outcomes with the visits. Now, some of the things we also, as we move on, what how would my patients feel? A lot of times I tell people, put yourself in the patient's view and feel what they feel. A lot of the times I tell my patient, I tell, young doctors or residents, I say, listen, do you know what it takes for somebody to come see you? Especially for those who are older. It takes a whole lot of effort. First, they have to dress up. Um, put in their clothes, those with arthritis and all that, cane, arrange for transportation if they, most of them don't drive anymore, or even if they drive, it's a big issue. So by the time they drive to come see you, it's an effort. And then when they come, they have to go through the whole process of insurance verification and all that stuff. And they come into the room, have to sit and wait, probably an hour, 2 hours for you. Sometimes they're already, aggravated already. So these are issues that we must, as providers, put into consideration. But at the same time, as patients themselves, they need to also understand when you come in to see a doctor. Some people have said that's why they call them patients. You have to learn to develop and exercise patience, because what you feel is more important to you. And most people, that's a lot of the time, self-centered. My problem is the worst problem on earth. I don't care if you have your hand dangling and it's going to be cut off. I have a finger stick cut. My problem is more important than yours, and I want to be taken care of seriously before anybody else. And that's some of the attitudes that some people bring when they come to the doctor's office or even to the ER. When people tell them, "Hey, you know what? Sit still or sit tight. We have more pressing issues," and then they get really angry. Now, cognitive bias and diagnostic errors. These are biases that can result in misdiagnosis by skewing how clinicians gather and interpret evidence, take actions, and evaluate decisions. Again, we are trained professionals, and that's why a lot of the time you go through medical school for what? 4 years, and then residency for another 3 years, fellowship or however, whatever residency you go, and all this gruesome, process you go through residency. And it takes a lot. And who and how you get your training matters a lot as well. And the influences that you get based on individuals who mentored you. And because of that, people come in with, biases. Again, there's anchoring bias where a clinician adheres to its initial impression in the face of conflicting evidence. Somebody comes in, again, I just said yellow eyes, black, it must be sickle cell. If it's not sickle cell, no, because that's what I was taught. It has to be sickle cell. No, but the liver is enlarged, yes, but it could actually be um, liver disease from accumulated what do you call it copper. That's what's causing that. No, because it's black and yellow eyes, it has to be. So, and that's based on anchoring biases because of prior exposure of all the patients that they have seen all through their career have always been black, coming pain, yellow eyes, and it's always sickle cell. But when something, like I said, when a zebra walks in, they don't recognize the zebra. So these are issues where, as providers, we must begin to pay attention as well. Now, for patients as well, what I also, and patients do come in with the anchoring biases again. Oh, he's black, he has an accent, he must be from Africa. No, he was born here. He actually schooled here, but you know what? He lived in Africa for what? For a few years and then came back. He's an American and he trained in the US schools, in Ivy League, as a matter of fact. But nobody wants to hear that because of the anchoring biases that, even patients come in with as well. Now, confirmation biases, information where we cherry pick to support diagnosis. Certain things that come up it's like, oh, it must be this. No, I have to make sure that it's this because this is what I'm most comfortable with. I have a headache with what do you call it? Uh, blurry vision and I'm vomiting. But you know what? Because you've always come here every time with a headache, and the last two, three times, I give you Tylenol, the headache went away. You feel you were stressed because maybe the husband was giving you trouble. then that's most likely what it is. But this time around, no, it's different. So we must begin to pay attention to some of all those things as well. Now, affect heuristics, actions driven by emotions that often manifest as strong feelings regarding a patient after an encounter. Um, Again, that's why initially in my introduction, I talked about emotional intelligence. As doctors, we must begin to truly, or providers at any level. And this is not just with providers as well. We're talking about medical gaslighting. But this kind of gaslighting takes place everywhere else. I'm sure there's what do you call it? Legal gaslighting. Maybe nobody's written anything about that yet. There's accounting gaslighting, and all of those things. Social gaslighting or social worker gaslighting. So you can actually truly apply this to these issues as well. Um, Outcome bias. Clinical results always follow prior decision, preventing clinicians from considering feedback to improve on their health care. And that's why in medical practice, you find that they ensure that you do continuous medical education. Because if you don't know what's the latest thing out there. You don't know that now we have CRISPR that we can use to delete genes and replace genes that will help you do well. You don't know there are new medications that TNF alpha blockers. You understand? That will treat you rather than using, steroids to treat rheumatoid arthritis. So because of that, we have this outcome bias that we're used to all our lives. So because of that, patients truly do suffer as well because your doctor, whoever it is, has not updated his or himself to better knowledge so they can adequately take care of you. I'll give a typical example. Some of us use the latest iPhone every time or Samsung. If you give somebody, I don't know what the level of iPhone or Samsung is out there right now, but I'm sure it's more than 15. So if you give somebody iPhone 15, they'll throw it back at you, because listen, we have the latest one that do so much better. And I'm talking about the one that's coming out soon with the AI application that's going to do so much more for us. So upgrading and updating ourselves is important. And that's why, even for patients, you need to read. I know people do Googling all the time, but when you Google, you have to know how to Google. Just don't Google chest pain. No, you could say chest pain on the left with dizziness and whatever. You find that it will narrow it even so much better for you so that you would better understand what they're trying to tell you. Because if you just say chest pain, it's going to give you some of the worst things are the first things you're going to see. You understand? So if you see chest pain and you having dizziness and you having, blurring of vision, you have nausea along with it. So put chest pain with blurring of vision, nausea. You'll be shocked that, oh, abdominal pain. It may just be hunger pangs, and it's going to tell you straight up, rather than, oh, abdominal pain, it's going to say cancer, and then everybody's freaking out.
Hello.
That's what usually happens most of the time as we do
Good
the
evening.
things we do. So as you go on to improve on your knowledge and studying, especially if you're a person of color, you have to
Who is this?
study to improve on your medical skills.
Are you in town?
And improve on your medical knowledge.
Sorry about that.
For your own sake. Then it's imperative that you, and if you're in doubt, listen, ask somebody else. Ask somebody who's not your primary care physician or whatever, to explain these things better, so that when you go on to your primary care physician, then you'll be able to ask those questions. As a matter of fact, while we're on that, if there's any one of the primary paramount things you take out of here, everybody here ought to have a primary care physician, period. You have to have one. Somebody is a point of reference to you and for your care. Who's going to round everything up and look at it objectively and then direct you like what do you call it, a traffic man in the right direction that you ought to go and do better. Because people who have primary care physicians have better outcomes than those who don't have primary care physicians. Because otherwise you end up going to the ER, and the ER, they don't know you. And a lot of times they just do what is expedient for them at that point in time, just to get you out of their hair. And of course, you may come back or things may get worse again. So please have one. And outside of having one, establish a great relationship with your primary care. Um, Health is wealth, they say. If your health is not good, guess what? Everything stops. Everything. Uh, if one of us were not feeling well today, we will not be here sitting down listening to this lecture. And if I wasn't feeling well, I would just have to say, doctor, oh, sorry, I don't feel too well. I can't come. And period. And everything stops. And that's why we must begin to take health uh, as a critical or crucial issue when it comes to our life and livelihoods. We saw what happened with COVID, where the whole earth stopped because the earth was sick. But building a relationship with your primary care is important to the point where they will view things, review things properly, and preempt things that are happening. Every doctor, a lot of the time, healthcare provider want to do the best for you, and they also want to impress you. So, but if you have a good relationship with them, guess what? They will do those things and go the extra mile um, for you. Just like the lady at the pizza store who put an extra, pepperoni for you just because they like you and how you develop a relationship with them. That's human nature, and that's just the way it is. So general guidelines. These are some of the things that as we begin to talk and move around with things. Um, we live in a world of technology where technology is answering a whole lot of things. Where each and every one of you, I see patients now like, oh, doc, I'm on my chart. And everybody has an eye chart. They go online, they see their results, they see everything. They may not be able to interpret it properly, and they come, he's like, Doc, I see the, and those for some who have my cell phone, they'll text me like, Doc, I see my white count is so low. What does this mean? I may explain to them right there and then, or say, you know what, come into the office so we can, have a better discussion if there's a need for it. So everybody have access to their health um, health records, at least to a large extent. And people look at stuff. So as healthcare providers, you have to be careful what you document. Gone are the days when you write a whole lot of things on the chart and not because nobody sees it and they don't see it. Now it's electronic or on the paper. Now it's electronic medical records and they have a right to see because again, we have realized that patients who are involved in their healthcare have better outcomes um, in their healthcare. And not just that, it helps to reduce the disparity that comes about it so that you know what your provider is thinking about you or what they're thinking about, when they document what they document. For instance, if I come see you and you write, hey, he's a drug seeker. I mean, and I see that, like, doc, when was the last time I came seeking drugs from you? You understand? All I asked for, for tramadol because I went to play soccer and I had this swollen leg or whatever. No. Um, the doctor may say, oh, you know what, because you're black and you come here and asking for tramadol, you're drug seeking, and they document it. I can ask the doctor and say, no, doc, that's not what it is. You have to change that. Yes. Providers have to come to terms and understand that yes, patients will have to ask them questions. They have the right to look at the charts for a number of reasons. It helps the overall care of everybody and puts everybody in check. So as we move on, healthcare providers, you need to know what you document on the ground. And as patients, you ought to also have access to your chart to see what's written about you. And sometimes you may go to the ER and somebody will document, maybe by mistake or whatever, psychotic episodes. No, you just came in there because you have overt headache and you were really anxious because of some exam that you were supposed to have taken yesterday, or you didn't do well in an exam or a promotion test, and that's why you had an episode. But to say psychotic, no. And unfortunately, that diagnosis will follow you all through to the point where by the time you're applying for life insurance, guess what? It's right there. And they'll look at this. These people look at this stuff. So it's important that you also look into your medical records and see what has been written about you so that you know how to correct things that need to be corrected. Again, these are the things. So things like labeling or stereotypes, communicating patients' conditions. Example, a difficult patient. The people write that. Who is a difficult patient? so that when the next person sees that in the hospital or the ER, in their head already, boom, the stereotype. Before you even walk into the room, this one is a difficult patient. So they're all angst already. Their anxiety level is really high. And by the time they come in, they're ready to fight, which is not true, because somebody wrote that 4 or 5 visits ago because you just didn't like the way what do you call it? They express themselves or the bad manner, bad bedside manners. So rather than doing that, you could say the patient's experiences active objectivity in an individual manner that promotes patients' best interests that will happen among providers. Discount the patient's identity, uses assumed gender or data or labeling. Yes, and these are things that really do affect people, especially now we live in a he, she, or world where people are really confused about what what identity people need to ascribe to. So again, it's being sensitive culturally or ethically. We need to have empathy with that. Being mindful of our languages. Um, Patients a medication abuser, patient seeking legitimate help for his or her problem. And that's the anti-bias. I already know he or she is here. The patient, uh, I already know why he or she is here. You don't know why they're here. It could be something else. Or they may even be bringing a family. But because you saw them 2, 3 times and they're here again, you're like, oh, rather than saying that, you could say, I wonder why he or she is here today. Now, the patient is the cause of their own medical condition, smoking, alcohol, etiolated alcohol. Now, rather than saying that, you say, I would assume there are multiple reasons where this patient that may have occurred. We may need to look into um, many reasons why. Look, you don't know people's story. You don't know why they're alcoholics or why they smoke. You have no idea what their story is. And because you see them, nothing's written in the face. To assume those biases, cognitive or whatever biases that we carry around as providers and even patients, these are times where we have to, again, learn those um, emotional intelligence in addressing some issues so that we will have our best encounters any point in time with everything we do, including the healthcare. Now, I refer to a specialist who will have more time to review your case. Providers have said that. I'll refer to specialists because they just want you out of their hair. Who have more time. Words matter. How you say and what you say matters a lot. And people pick up stuff. And before just saying that alone, they're really pissed off. And we must understand also that patients are a whole lot more informed than the patients that our fathers or forefathers knew about. And for other people, other races who deal with people of color, they must also understand that, listen, Black and brown community, they are a whole lot more intelligent, far more intelligent than they were assumed, and far more educated now than they were assumed to be. So things need to change. And these are the reasons why um, these steps have been put in place to address this issue where you can see your medical records as well. Now, instead of saying that, you say, I will review this condition and will come up with a good plan and will refer you to specialists with better expertise to help or co-manage. Because when you are referred to a specialist, there's a reason why you refer somebody to a specialist to get a better idea of how things are happening. You have another reason you could do that, reason number two, is that you refer the person to that person so that you can co-manage the patient with the person. And the third reason is like, hey, you know what? This is your space. You take care of this, and I will watch and get your report. And those are the three reasons why people refer people to. Now, on the patient side, patients come like, oh, I need a neurologist. And the question like, why? I have a headache and it's been gone for 2 days. So I need a real neurologist. And patients say that a lot. And a lot of the time they don't know how badly it pisses off the provider. It really does. Because you just come with an assumption that you know what's wrong with you, which, as a matter of fact, you really don't know what's wrong with you. So it's important that as providers and as patients, we begin to take that time to review how we approach one another and how we approach our healthcare encounter so that you can get the best um, healthcare encounter or management as much as possible. Um, so that your care is important and it's imperative that you get the best care that you can. Uh, what's to avoid? Disabilities. We do that all the time when we write about stuff or even say things and document it. Again, like I said, this is not just in the medical field alone. In other fields where you are at risk of being biased or using words that derogatory to somebody, you need to pay attention to that. We often say wheelchair bound, and unfortunately, that's what we learned. We've written that for over 50 years. You know, oh, that patient is wheelchair bound. No, it's a wheelchair user. Oh, it's retarded. They use that a lot, but things have begun to really change now, where they now say, oh, you know what? He or she's intellectually disabled. And these are things that will help us understand how best to interact with one another and take care of our patients. Now, social history. Oh, the patient is homeless. Again, it's an ex-convict. No, patients are experiencing homelessness. And that's why if you hear in modern terms and people who are really very sensitive, you hear them say, oh, the patient is experiencing homelessness or is on house. They don't use the term, oh, the patient is homeless. Not anymore. We don't use that. Or the patient is an ex-convict, patient with a history of incarceration. We live in a world where, as Black and brown individuals, we've had people who've been in jail for 30, 40 years for things that they did not even do. We know that. So because somebody was in jail does not mean that they truly committed what they did. Even if they did, so what? But they paid their time and they paid their dues. They served their time, paid their dues already. So we need to learn to respect that and provide them the best kind of care as we see fit, and that was good for us. And as patients as well, when you come in, you cannot just assume that because you're homeless, then they're going to look down on you. No, because patients do come in with that attitude as well. Oh, I'm homeless. I live in a shelter. So anything that the doctor says or the healthcare provider says, oh, it just means that they don't like me or they're looking down on me. No, that's not true. Everybody has to give some form of benefit of doubt. Now, in the gender issue, like I talked about earlier, gender identity, he, she, him, her, and they. Again, these are things we're still learning. Even yours truly is learning those terms and terminology as well, and how to address this. Again, we have to learn. Address individual based on what they want to be addressed as, and you identify. And a lot of the time, the best way to say, how would you want to be addressed? Easy, call me a woman. All right, fine. If that's what you feel, that's what you want to be right now, yeah, it's fine. I had a patient who we were seeing for the longest time. Is a guy, gentleman, but he all of a sudden said, you know what, I'm a she now, and I need to be addressed like that. And it was a little difficult for some of my front staff, front front desk staff to understand that this is the patient that they've known and they've seen him for all these years. And then he's like, doc, he's here now asking to be called a woman. Yeah, that's what she wants to be called. So address her as such. It is what it is now. It may change tomorrow. All right, fine. Um, they're here to get care. And that's what they're primarily here for. So we need to be able to give them the care that they deserve. Medication and behavior, compliant and non-compliant. We use that a lot as well. It's a non-compliant patient or bad behavior. You understand? We could say words like adherent or non-adherent to medical care. Instead of saying promiscuous or patient with multiple sexual partners. These are some of the terms that we'll begin to use and people will have to get used to and understand how these things work. So again, as you look into your chart, I'm not saying you should go there and fish to castigate your provider and your doctor and begin to raise war against them. No, you'll be shocked. They may not just even know these terms or understand that in words that they're gaslighting you as well. Because like I said, a lot of providers don't even know what medical gaslighting is. And they do it on a daily basis because they just feel, oh, it's the right thing to do, or that's how they were trained. and they moved along with it, and they never saw anything wrong with it because that's how they were just trained, period. So, but because things are changing, our world is changing and changing really fast. We must get to a point where we understand how things work and adjust to them. We saw what happened with COVID, where again it's horses, and then what do you call it? Zebras came back. During COVID, patients who present respiratory symptoms suspected COVID, even after negative test results. The authors of the case expressed concern that physicians have become blinded from the COVID pandemic and even anchored to diagnosis of severe hypoxia respiratory failure to COVID-19. Everything that came around at that point in time was COVID-19, even if it wasn't COVID-19. They just felt it was COVID-19 because it was the most convenient thing to do at that point in time. And it just takes the pain and the stress of you wondering and feeling guilty about issues that you needed to address. So, and people just did that. But at the same time, we had people who came in with aseptic meningitis and died. And people just ascribed them. People came in with, disseminated coccidioidomycosis, which is a fungal infection that affect the lungs and the brains. And people died from it. So people came with pneumonia and all the other stuff that people died from, valvular heart disease, uh, but they just assumed that it was COVID. Meanwhile, it wasn't COVID. So these are the things that we must begin to pay attention to, so that we understand that, look, again, it may be horses, but there are times when zebras come back. We need to learn to understand what zebras is. And I use those terms like loosely but cautiously, because in your discipline, what are the zebras and what are the horses that you come across? And how do you, as a person of color, make sure that your patients or your clients are not victims to the so-called biases uh, that is in your industry, and how you not helping to contribute to perpetuate those biases as well. So again, it's imperative that we begin to pay attention to some of all these things, because it makes a whole lot of difference, um, how we interact with one another. Now, um, experience of people of color in our health reveal that implicit and explicit biases and structural racism are driving healthcare inequalities like maternal mortality, death rate. We did, talk about that in my opening statement, with those stats. Statistics is important. And one of the biggest issues that we've had in our domain, when I use the domain, the Black and brown community, we don't pay attention to things. And it's disparaging to actually say that Black people don't read. And Black people have used that word. In fact, 2 days ago, somebody told me, Black people don't read. And he's Black saying that. I looked at him. You understand? Well, a lot of the time, we don't pay attention to a lot of things. But one of the things each and every one of us here must pay attention to. Because, again, we also hear the panacea of data is king. Data is the new money. So for any one of us here, in your discipline, in your field, you have to know the data that is in there. Because when you speak, it makes you look sound, intelligent, the result you're coming from color. It would disarm everybody else when you come with data and quoting statistics. Again, it's important. And it gives you the flair of 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 uh, of knowledge, because a lot of people don't pay attention to those things. It may not come easy at first, but if you do it repeatedly, you find out that it becomes a part of you. It's taken me these years, and that's why over time I still keep that data, and then you can truly build on them as you move on. For instance, if you an OBGYN, you should know the number of the maternal mortality death rates in the country or across the world. It's OBGYN, for God's sake. You should know what's the maternal mortality rate in your state, in your locality, in the different zones that you look at. If you're a pediatrician, what's the maternal infant death rate? Um, and all that. If you're an anesthesiologist, how many people of color died from, you know, bypass surgeries? If you're a nephrologist, how many blacks are on dialysis? And how many of them, die as a result of not getting dialysis? Those are data that you speak from your discipline that will make you really smart. If you're ID, you have to know the 1990 what do you call it, criteria that the WHO have put out there so that we can help curb the spread of HIV and improve outcomes for HIV patients. So it's important to do this. So as we move on, um, some of the questions that they did talk about when it comes to healthcare disparities were how many people are screened for diseases? You as a healthcare provider, how many screening have you done to screen your people for diabetes, to screen your people for kidney disease? Because when they pass through you and they end up dialysis, they end up with diabetes, and they end up with stroke, and that you are helping to contribute to those numbers. You are. I'm sorry. People ended up on dialysis. You are. If you're a provider, you're not screening for this. And those data and the statistics that they talk about, you're helping to contribute to it, especially for your kind of people as well. Now, how many people um contracted certain diseases? How many people in your neighborhood had HIV? And these are numbers, or TB. We now know that syphilis is on the rise. Why? For who? And why is it? How many in your neighborhood? You understand? These are issues that are happening. In fact, a friend of mine was telling me some of the great work that they did in I'm not sure if he's here. It would have been cool if he was here, Dr. Osse, Emasielo. The great work that they did in Maryland that was a template for the rest of the country. It's called AHEAD program. AHEAD program includes the acronym where everybody who comes to the ER emergency room in Maryland was screened with an A1C because they needed to know what their diabetes status. By doing that, they are channeled into the proper care that needed to, and the cost of care is reduced. They calculate all of this, and so that in the future, reducing the number of people with dialysis and all that, those things eventually save the system millions and hundreds of millions of dollars. Those are steps that needs to be taken. And in your field, in your space, find out innovative ways in reducing the healthcare disparity or whatever disparity that's in your space. That's how we move up as a people, and that's how you create progress for your people. So as we move on, severe disease, how many of them had that? How many people had complication-related diseases? How many people died from the diseases? Whether people had access to healthcare. These are issues that result in healthcare disparity. So what are the recommendations? Recognize that one, healthcare disparity exists, is real, and knowing how it affects everybody. What are the diagnoses? Develop organization understanding of the depth or cognitive biases that affect patients, especially if you are in the healthcare industry one way or the other. And as a patient, look, you have to be an advocate for yourself as well. Read, study, and when in doubt, ask somebody. Really do. Ask somebody. But above all, develop a relationship with your primary care so that, God forbid, when you end up in ER or in the hospital, you have somebody to call and who will be an advocate for you, and your outcome will a whole lot better than anybody else. As doctors, I had colleagues of mine who were admitted in the hospital who had issues as well, where by the time they came out of the hospital, they were treated worse than anything else. And they had no, because they didn't say anything. And people would just assume because you're black and you're here, it doesn't matter. And they'll treat you the way they want to treat you. And they'll treat you like everybody else. Whether you're a doctor or a PhD holder, it doesn't matter. Now, one of the cues I tell some of my patients and all that, tell them, listen, you have a family, your uncle, your brother is a doctor. People pay attention to you. They really do. You just tell them, I have a doctor, throw a name, or give a name of your primary care doctor. Oh, my doctor is Dr. Okwesemi. They know how well. Listen, they'll pay attention to you. You understand? And people who know your doctor are like, okay, Dr. Besame is a diligent doctor who's hardworking and who knows her stuff. And she's worth her onions. So if they'll pay attention to, they'll call you. I've had a case where a patient of mine who I found out the wife introduced to me, and by the time I did the blood work, this is someone who works 6 days a week. And the wife is a nurse practitioner. I had mentored her back in the days, when she was in nursing school, nurse practitioner school. And like, oh, Dr. Aluya, he won't take his medication and all that and all that. I said, okay, fine, bring him. So what are you doing? He's on blood pressure pill, but he's not taking it. So he came in, looked at him. I eventually happened to know him. And I know he works 6 days a week. He's healthy, no problem. He came in, blood pressure was a little high, no big deal. So, okay. I said, are you taking medication? Yes, I am, but the pressure is nothing high. So I said, all right, fine. Let's do some blood work background. And I sent him away. Follow me up in 2 weeks. Now, this is one thing. Probably I've said it here before. Um, Listen, if you do your blood work, again, these are some of the reasons why the healthcare disparity is so big amongst us as well. Because even us as patients, we don't follow up our tests. I always tell people, if you do a test, anybody listening right now, if you do a test, follow up with your doctor in 2 weeks, period. Because look, doctors have so many things to do and they may have distractions. They may forget. And the piles of labs that come in and all that, and God forbid too, he may actually be very busy when he's looking at your result and he missed it, or he was looking at it and then he got called from somewhere from the OR or whatever. At that point in time, he got distracted, and by the time he came back, there was a flicker, boom, he moved on to the next patient, missed yours. Your results is sitting down there. There's something wrong. He hasn't seen it. You need follow-up. 1 year gone by. So if you do a test, MRI, CT, anything, set up a meeting with your doctor for 2 weeks as a follow-up. Let your doctor sit with you, review that test. And that's how you will help contribute to reducing healthcare disparity, period. So, coming to this gentleman, the results came back. I was shocked. The guy was on dialysis level. Dialysis. His kidney function was dialysis status. I couldn't tell the wife. I couldn't tell him. I said, you know what? I think there's something wrong with this result. Let's do it again. Maybe they made a mistake. He came back. What's the same? So I had to figure why his kidney function was so bad. He had no idea, working 6 days a week. By the time I did the ultrasound, I saw that he had polycystic kidney disease, cysts all over the kidney. How many of us sitting down here now know if we have a cyst in the kidney? I don't know because I've never had an ultrasound. Never, some of you don't either. So until you do those things, you will never know. And he's working 6 days a week. So because of that, I had to no ibuprofen, no naproxen. So we had to take steps from him eventually ending up on dialysis. Now, why is this bringing this up? Because eventually I kept him like that, no dialysis, nothing for 2 straight years. And then one day I got a call from a doctor in one ER somewhere. They said, oh, doc, your patient is here. His kidneys, he's on dialysis. We're going to set him and put him on dialysis. What happened? He went to the ER, he went to the hospital. He was about stepping out of the hospital, he tripped and fell. Because he tripped and fell, they're like, oh, something wrong. You're here, go to the ER. So everybody said, go to the ER. He went and they drew blood, and that's what they saw. So I got called. And it was what, 12 o'clock in the morning. So I said, listen, leave him alone. Leave him alone. He's been like this, and I know he has polycystic kidney disease. So they didn't dialyze him, they didn't put him on dialysis. So for the next 2 to 3 years, he was without dialysis, still working 6 days a week and living a normal life. So these things happen. Once you have a good doctor and you have a primary care, they will reach out to your primary care. And we're talking about how you help reduce, healthcare disparity as a patient on carrying out your individual responsibility as a patient in the care of yourself. And I always tell people, I said it here before, that a provider would often see you 15 minutes at a time. The only time he sees you more than 15 minutes is in your annual well physical. and everybody should get one as well. You can see your patient, you have diabetes, you have blood pressure, whatever, but have a once a year because you are entitled to that. Irrespective of what outcome you have or healthcare challenges, you will sit with your doctor once a year where you get 30 straight minutes with your provider discussing your healthcare and other surrounding issues, including the medication that other people gave you. Because again, these things can interfere with certain things, including that so-called uh, innocuous multivite that you're taking from the herbal store that may actually be damaging your kidney and you had no idea. You understand? I had to tell somebody today because I was shocked. The kidney function was so depressed. And I had to tell him, like, listen, this is, and then by the time I started asking, I realized he was drinking 6 cups of coffees every morning. Six. So if he hadn't told me that, I like, listen, this is not right. Your pressure is good, everything is good. But why is your kidney? I know you have diabetes, you've had it for 20 years or something, but then, it shouldn't be like this. You understand? So I had to say, cut back on dialysis, on your coffee and get yourself hydrated because coffee can dehydrate you as well. So these are the issues that as providers, when you sit with the doctor, you have to open up with your provider in discussing critical issues that may be with your disease and also surrounding your disease. And that's why once a year annual well checkup, it's important. So moving on, we will have to implement mindful procedures to support clinicians in overcoming biases. And that's what healthcare industry can do. And individuals, you and I, and people who are in the outskirts, if you're on the board board of directors of a hospital complex or whatever, uh, without that, you can actually advocate for doctors. Back in the days in this country, doctors used to work over weekends and then they still come back in the morning, Monday morning to come. A lot of people, patients were dying. People advocated for them to stop so that once you do your 24 hours call, you have to have at least 8 hours of space or rest in between before you get medically engaged again. So these are the things that people did in the healthcare industry by advocating so that we get to the best care that we have right now. So moving over, using simulation training to help clinicians and all the biases that we have, uh, dealing with each and every one of them. Incorporating critical thinking methodologies to increase clinical objectivity. Again, that's our role with teaching, especially those who teach and teach younger ones. For those who are in the nursing field, again, these things are really important because guess what? I heard somebody's in a nursing doctorate program. Yeah, you become a doctor as you also teach all other young ones coming up. These are some of the things that are critical and crucial that we must also begin to teach um, young doctors as they come so that they get, give best care as much as possible. Limit patients' descriptors, frequent flyers, drug seeking, as we do. And as again, patients, you need to be able to, stand your ground, do your research and see how things work or what's written about you in your chat. Assess organizational cultural competence, identifying both strengths and opportunities for improvement. Develop healthcare providers cultural competence. Again, these are training and education for us and for those who are in the healthcare industry. Periodically assessing cultural competence within the organization as well as progress towards specific goals. So these are some of the things that we put in place to help educate, inform doctors and even people who've been practicing for a long time because these things really matter. So I'll just move on to. I don't know. It froze. Can you guys hear me?
Yes.
Okay, good. So, be kind. Being kind means responding to the needs of others. And people can be kind, no matter how old or young we are. And that's the word of Fred Rogers. Be kind at any point in time, because you never can, even by a smile, you never can tell whose life or mood you've improved for that day just because you smiled at them, or just as you walk by, to say, "Hey, how are you? How are you alone?" Makes a whole lot of difference. Be kind, for everyone you meet is fighting a hard battle. Everyone's at a different stage in their life, and we're all fighting the battle one way or the other, either personal or family or however. So it's important for each and every one of us to show kindness. Again, it's reciprocal. What you put out in the universe often comes around as well, and you get that. So I must say at this time, I hope I've been able to help educate us and enlighten our minds well enough to understand there's medical gaslighting, and it's a pervasive thing that's taking place in our community, and each and every one of us have a role in helping to stop it. Thank you, and God bless.
Wow. Thank you so much. Medical gaslighting seems like a physician bashing.
Who
But
have
things
you
are
been yelling
changing.
at, Doctor? Oh, you lost your voice. Who you been yelling at?
I've not been yelling. I've been under the weather, but
Oh,
I wasn't going to cancel Medical Mondays. And
yes.
Here we are.
Okay, we're going to DoorDash ogbono soup to you now.
That would be fantastic. All the way from California. Thank you, Madam VP. So, Dr. Aluya, this has been fantastic. You know, things are changing in medicine. We don't use the word gay anymore. You know, in my territory, that I know very well, is men having sex with men or women having sex with women. We don't use the word drug addiction, it's substance use disorder. And people returning is what we refer, it's what we say of people who are just coming back from prison. Like you rightfully said, they've paid their dues. They have sometimes they didn't do anything, you know, as you alluded to, and got imprisoned. And even if they did, they've paid their time. So we need to have respect. Thank you so much for this education. And I hope we have a lot of medical practitioners on tonight to learn, and even patients, because it goes both ways. I also learned something. You said the word patient, you know, probably comes from the word patience, that patients need to be patient when they come to the clinic setting or the hospital setting. It reminds me of the emergency room that people are complaining a lot about now these days, that they spend hours in the emergency room. And it's because sometimes people don't understand or appreciate what emergency room is for. It's actually for emergencies, not to go fill your prescriptions that you need to fill with your primary care doctor, or you know, for mundane things that the physician, that the primary care doctor will take care of. But in the emergency room, when you show up with those things, they still have to triage and all of that. So patience. Thank you so much. I learned so much in medical gaslighting. Madam CEO, Madam VP, kindly unmute. Kindly unmute. You have your hand raised. There you go.
Yes. Okay. Yeah, I hope you feel better, Dr. O. Yeah,
Thank you.
it's a fantastic presentation. And Dr. Aluya is right about patients being impatient when you get there, especially when you have an appointment and the doctor cannot see you right away. But some of the language requirements that he mentioned are essential, not just in the medical field. We have to learn to use language that does not objectify people or is demeaning to them. It's number one part of healing, even in the LGBTQ community. Now, in terms of letting your physician know that, oh, you have a family member, Dr. O is my remote doctor, that kind of stuff. How much does that help to put a physician, I don't want to say put them on edge, to kind of make them more cautious in giving you a full attention or full scan or diagnosis or whatever it is that you need? Because like you said, Dr. Aluya, there's some things that are hidden inside of us. If I've not had a scan in 5 years, I'm not going to know. second question is, what is legitimate, depending on your age group, of course, if you're over 60, what are those things that you need to request your doctor for? Because for me, I have Kaiser, and Dr. Ho hates Kaiser. She passionately hates Kaiser. And because they are HMO, they give you the BRS minimum. Every time I talk to her about something, I don't like Kaiser. So what are those basic things that we should be asking our primary care provider for? Because they're not going to freely offer them to us.
Yes, so thanks, Madam Lara. Pertinent questions. One, to your initial question. Yes, telling somebody, not throwing it at their faces, but just kind of hinting, oh, like I said, oh, I have a primary care physician. It actually de-escalates the anxiety that the person in front of you who's giving you care, it actually de-escalates the anxiety in that person, because it's like, you know what? Okay, if I miss something, if I don't see something, I don't know something, I have somebody to call, so they'll be able to call you. That's one. Two, it also um, heighten the alertness of that provider and say, you know what, I don't want to make a mistake here, because then guess what? Somebody may also may have a question, or maybe be able to ask why. Those things matter. I've seen it multiple times where someone like, oh my God, why didn't you tell me that the father or the mother is a doctor? And the third one is we see it as a what do you call it? A professional courtesy as well. When we take care of a family member's, a fellow physician's family. Back in the days, when you go to the hospital as a doctor and you identify, there are a lot of times they give you discounts. Or when you come to a doctor's office, I hear they don't do that anymore. If you come to my office and you're a doctor, I like, don't worry about the copay. Again, those are professional courtesy. So these are the reasons why hinting that you're a doctor or you have a family member as a doctor really does pay, because again, it's a win-win situation. God bless us, especially if you're a person of color. It really does help. To the question number two, and that's the reason why, and towards the end, I said you have to have a primary care doctor, because that doctor will spend 30 minutes rather than 15 in 1 year addressing those issues with you, where they'll be able to see it and ask questions. 30 minutes. Because if you keep coming every time, it's a sick when you're sick, or when you need something, I need paperwork for you. Just sign it, just sign it. And every time that's how you come. Again, there's a bias being built into him or her. He's here for paper or he's here for sick. You never show up for your annual well visit. So I don't know what's wrong with you. I can't help you. But it's imperative that the doctor at that point in time, because we have criteria, the things we need to. And I've said it a couple of times as well. First, when you're going to see your doctor, especially for your annual well visit, listen, it's like going to church. I'm sorry. You have to dress up. You have to you have to clean up, you have to dress up, put on your best clothes, and appear nice. Because our people say, and I'll say it in Bini, domo. What it means is you are dressed how you dress. Period. You come in looking nice, sharp, people will respect you. I had a patient once who came in, and this guy was looking scraggy. He was like undressed, I mean, just like came off the hood or something. And it was my first time seeing him. We talked, we did. I said, listen, next time you come here, don't come like this. Cut your hair, put on the nice clothes and whatever. And by the time he came back, I didn't even recognize him. And by the time I said, it's you, he said, Doc, you asked me to dress up. And I said, yes, I am. He was wearing a suit and looking really nice. So, and that's how he maintained it, So, getting ready and then documenting the things you need to ask in order of priority. Whatever the problems are, you document them in order of priority. And this is the time where, before you go for your annual check, find out who your family history, your new cousin, who is there cancer in the family, is there new diabetes, is there anybody on dialysis, and all that. So that when you see your doctor, like, Doc, man, my brother just ended up dialysis yesterday or 2 days ago. And then you're like, oh, your brother ended up dialysis, so what does he have? You begin to ask those questions. Because one of the questions I always ask, if somebody has dialysis, right? And they come in, I always ask, what are the complications that your brother or sister, or ask, who else has diabetes in the family? You say, my brother or the mother. I say, what complications did they have? Because that's the most likely that complication you will have too, because you carry the gene. If it's stroke, some families is strokes. Some is visual, they go blind. Some they end up on dialysis. Some is amputation. So if you ask those, you'll be able to, streamline as a provider, as a healthcare provider, some preempt those things, so that you can safeguard the person's kidney, prevent stroke, and all that. So as you write those things down in order of priority, again, you come in and sit with the doctor. And you, because you've written those things down, you'll be able to ask specifically those questions. And the doctor will be able to go through by through. And it's okay to say, doctor, I have 10 questions. It's okay. And then so that he breaks his mind that, okay, I have questions, so that he doesn't talk too much as well. Because some doctors, they talk, and they forget themselves as well, want to explain, and some don't explain. But at least it keeps it a whole lot more prompt, direct, and rationally objective. But again, things you must know. One, your blood pressure. Two, is there any change in your weight? If there's change, you will know. But some people don't want to know, especially a female gender. They don't want to know their weight. But it's important that you get to know if there's a change, drastically up or drastically down. Those things really do make a difference. Three, what is your diabetes status? What is your A1C? You have to. Diabetes is the bane of our existence. Like I always say, it's going to change our DNA. I'm sorry. You have to know whether you're pre-diabetic, meaning, or no diabetes, or pre-diabetic, meaning you are at the stage where eventually you will end up as being diabetic. In this country, 2016, 88 million people were pre-diabetic, with 29 million as diabetic in 2016, when WHO and the CDC decided to say diabetes is an epidemic. Today, that number has gone up to about 98 million who are pre-diabetic, from 88 to 98 million. And those who are diabetic today are 34 million from 29. So you see, diabetes is matching. And unfortunately, if you're pre-diabetic, you have a 42 to 45% chance of becoming diabetic in the next 4 years. That's the data. So it's important to know your diabetes status. Are you no diabetes? Are you pre-diabetic? Or if you're diabetic? Now, share that information with your family members as well. Gone are the days where you say, oh, it's voodoo, or I don't want them to know. Because if you share with your family, they most likely will share with you what they're going through as well. So that will really help you in how to manage your case. We as people, we don't like to share our medical history. We don't. You ask them, well, I don't know. You understand? Because they don't tell you. I don't know. I mean, it's crazy to think that the same group of young children you grew up with, eating, sleeping together, you now become some form of competitive enemies. I don't get it, but it happens. You understand? It's important to know what's going on. The other one, ask when they do blood work. Doc, do I have any protein in my urine? Because once there's a protein, or do I have protein or sugar in my urine, it therefore means the kidney is not functioning, is leaking. That's what basically what it means. The kidney is leaking. If the kidney is leaking, the first thing you do is begin to spill protein. You see it in you won't see it. There's what they call, you see, back before that, we had just protein. Now we have what they call microalbumin. So the word micro, that's when the very small particles of protein, before they really become big proteins, the microalbumin are the ones that begin to leak really first. And if you catch that on time, there are medications, they'll put you on it. Take those medications for 1, 2, 3 years, months. You repeat the blood work again or urine, you see that those microalbumin is no longer there because they protect the kidneys. I had a discussion with somebody today about that, and it's imperative. And for some one of them, I said, listen, I'm going to put you on this medication. It's a blood pressure pill. Like, doc, I don't have blood pressure. Why would you have putting me on blood pressure pill? I said, no, I'm not putting, it's a blood pressure pill, but I'm not using it for blood pressure. If you notice it's going to be small dose, we're putting it so that it will protect your kidney. And I often use this. You see, if you see my hand, you see how all the areas are closed, so that when sugar comes, it filters through. when blood comes, it filters through. This is the kidney surface. When protein comes, filters through. Now, if there's a problem with the kidney, the first thing that starts to do, you see, they begin to have spaces in between. So the cells begin to open up. They're called the podocytes. Now, it therefore means it's now going to leak through. You see, the protein begin to, and the more the bigger they become, the more the damage to the kidney, to the point where it's so loose, you end up on dialysis, you can't function. That's just an illustration of how it is. So as we protect ourselves, these are some of the main questions we must begin to ask our doctors as well, including other stuff.
Thank you. Thank you so much. So Dr. Aluya talked about vitals, basically, when you go, but Madam VP, there are other things, like the standard for breast cancer screening has changed. Some school of thought said it should be started later at 45, some at 50. Now it's changed back again. Very, very brand new information that from age 40 to 74, people should screen biannually every other year. But radiologists will tell you screen every year. And I've talked to some, cancer survivors that say, a lady said she was diagnosed at 40. And she definitely will advocate that people screen every year. So that's a conversation to have with your doctor. Until age 74, it is important to continue to have mammogram. But after 74, from 75 up, there is no, we have insufficient evidence as of now to know the benefit or the, benefit or lack of screening over 75. Another thing is colonoscopy that we used to start at the age of 50. Now, please ask your primary care doctor from 45. You need to screen for colonoscopy. And if you have family history, then it will be done earlier. 10 years earlier, Dr. Aluya talked about family history. It's very important. If somebody has family history of colon cancer, then the screening will be started 10 years before the age of that family member that has it. But right now, instead of starting at 50, we start at 45. And people will be screened every 10 years. If there are no polyps, there is no problem. But if there are polyps, then the GI doctor will guide as to when the next screenings should be done, depending on what kind of polyp is found. Pap smears are also important, and depending on if somebody has had abnormal pap smears before, if they haven't had it before, it is started at age 21 instead of 18 that we used to, or when they start having sex. So we start at 21 now, and depending on the history of the woman, they'll be guided to how often they have it. So, maybe those are key things to talk to the doctor about, including, those screenings for diabetes, high blood pressure, the kidneys, and all that Dr. Aluya alluded to. And if somebody has issues with, even hyperglycemia, meaning the sugars are high, but they have not reached the point of diabetes yet, we recommend that they check it every 3 months, because you never know. Things can change like that if they don't change their lifestyle, or they don't, change whatever it is that is pushing them that way. So it's important that they check every 3 months. So everyone has to be treated as individuals, and the primary care doctor is the one that will guide that.
Awesome. Thank you so much, ma'am.
You're welcome.
What about brain? Can we scan for brain?
No, we don't have standard screening for brain yet. And it wouldn't make sense. And again, I want to say this. If you screen the whole body from brain to feet, you will find something. And it may mean nothing, just incidental findings that may cause anxiety. So in medicine, I went to medical school in the US. We were trained that if you cannot intervene, don't screen. So all the screening tests that we do is because we can intervene. If we can't intervene, we won't screen you. So unless there's a reason to scan the brain, we don't scan the brain. So we won't go into that now so that we can answer all the questions, the reason that most people.
Let me take that quickly, because it's really important. And in our community, a lot of people have died, from senators to even here in the United States, died suddenly, and they died from an aneurysm.
Yes.
Now, and they don't know that. But guess what? Aneurysm runs in family. If you have a family member who died suddenly, and they said it's a blood, an aneurysm, a bleed, it's imperative also that at any point in time you can get screened. Honestly, and the last word that you said before
Your
this,
insurance will not pay for it. I still have a patient.
again,
They today.
I hear you,
Insurance
but who
refused.
cares? There are certain things that they don't pay for, but you have to pursue. And I'll tell you why. I'll give you a typical example. One of the
How
words,
do
the
you
last
pursue
words you
it?
said was that everything ought to be tailored. And we're getting to a point where in the future, it's personalized medicine from medications and everything else that we're going to do. That's what we're heading toward, including the medication that you're going to take. Individualized medicine, because everybody's different. And I've said it before that you eat an egg, you're fine. I eat an egg, I end up in the ICU. Does that mean eggs are bad? No, it's just bad for me. Now, when I gave the analogy earlier on of the young man who had polycystic kidney disease were ending up on dialysis, ended up on dialysis. Now, polycystic kidney disease, when you look at it, there are criteria for it, in the sense that if you have multiple cysts in both kidneys, then you have to screen for the liver and make sure that the livers don't have cysts. Now, if there's a cyst in the liver, guess what you have to do? You have to, it's the standard of care, you have to do an MRI of the brain. Because if there's a cyst in the kidney, cyst in the liver, there most likely be something that looks like a cyst in the brain that eventually end up as an aneurysm. So
okay, Dr. Aluya, I don't want us to belabor this. Like I answered.
What I'm saying is,
what I'm trying to say, hold it a minute. I said it. You have to have a reason to get brain imaging, period. In the United States today, we practice in the United States individualized medicine. It's not a thing of the future. And I said it earlier, even, some screenings, we will screen some things that is not standard because it is indicated in the person. So if you have reason to have your brain scanned, it'll be scanned. You can fight insurance for it. But
correct.
if you don't have reason for it, insurance will not pay for it. They won't do it. Radiologists can fight all they want. They will not do it. So, but if there's any reason, we'll do it. But it's not the topic for tonight. It's why I don't want us to go in there because we have a lot of questions. It's just that you have to have a reason to get it screened, period. Do you agree, Dr. Aluya?
Well, again, we're saying the same thing. You have to have a reason, but you have to have that reason following what your history tells you. And you have to be an advocate for yourself, basically. You have to, because one death from one person is way too much in a family. So if there's something that runs in your family, and that's why we emphasize again, you have to know your history, you have to share that history, family history. And if it is, then you pursue it. It's your history and it's your life. You need to preserve it.
Thank you. That is true. You have to have a reason, but then I wish everybody can get brain scans of some sort, like we do CBC. It's not happening yet. I don't know what the future holds. But before we go on, I want to say that we have one of our very own, Dr. Ajagbe, in Monaco right now. The 6 hours ahead, and I think he's getting jet lagged. It's his birthday today in Monaco. So it will be his birthday tomorrow. So I want us to give Dr. Jagbe a Medical Mondays happy birthday greeting that is so well deserved. So Dr. Jagbe, happy birthday. We wish you a very long life and prosperity, and pray that, you will continue to thrive in great.
Amen.
Amen. Happy birthday, man.
Kindly unmute and wish him
Happy birthday,
Happy
Professor.
birthday,
Hallelujah.
Happy
birthday, sir.
Hallelujah.
Happy
Thank you,
birthday to
everyone.
you.
Thank
Congratulations.
you,
Happy birthday
thank you,
to
everyone.
you. God bless you. No, for
Thank you
us.
so much.
Happy birthday to you.
May the
Wow.
good
Thank you,
Lord bless
everyone.
you.
Many happy
Hooray.
returns.
God bless you now. Amen.
Thank
God
you.
bless you now.
Happy birthday,
Thank
Dr.
you.
Bless
Happy birthday.
Hip, hip, hip.
Thank you.
Happy
Hooray.
birthday, Dr. Jagbe. To
Thank
say
you.
After
Many
all the
happy
Thank
songs,
you,
I have
everyone.
call. I have
bring the
cola
cake
nut
for us,
here for
so we are
you.
waiting.
Yes, so we are waiting for the cake. Don't eat it alone.
Dr. Jagbe, don't
Thank
try to break
you.
dance so in Monaco. You're not spring chicken.
Cook out.
Don't try to break dance so.
And don't try to break downs in Monaco. Is that what you
My,
said?
my hands
Yeah,
are up.
because you're not spring chicken.
my, my hands are up. I'm not breakdancing.
Enjoy.
Thank you.
Enjoy.
Have a good
Enjoy.
time.
Yes. Yes.
Thank you so much, everyone. I really
Yeah.
appreciate everybody's contribution to the Medical Mondays with Dr. O for the past 3 years and over. So we're building some kind of longevity as it is now. So thank you so
Amen.
much, everyone, for coming every week for the presentations. And I'm sure everybody is having a brighter future because we're learning things to be more proactive. And thank you, Dr. Aluya. I think one of the comments I put in the chat is that we need to exemplify the practice of, not just the golden rule, treating others the way we would like to be treated, but also to be mindful when we interact with others. So I just wanted to share that because I may just go to sleep now because it's already past 2:30 here. So thank you everyone for the birthday wish and greeting. Well, I really greatly appreciate all of you. Thank you very much. Thank you, Dr. O.
Thank you so much. Thank you. Enjoy, celebrate.
Get some chicken soup for your throat too.
I don't eat chicken.
Yeah.
Make some soup, pepper soup or something.
That would work. Pepper soup would work.
All right.
That is
Blessings, everyone.
Yeah.
Thank you, everyone.
Thank you.
Amen. Amen.
Bye.
Bye.
So, Dr. Izugu, you have your
Yes.
Go ahead, sir.
Yes. Dr. Aluya, thank you so much for that presentation. It again underscores the importance of prevention. Prevention, for us, everybody can afford prevention, but illness is a big problem and costs a lot. And if we take care of ourselves in a preventive way, we save life and have better lifestyle as well. As one of the Chinese proverbs, I don't remember the details, but they say that excellent doctors prevent disease. The good doctors treat illness. But student doctors cause illness. So let's aim to be more of preventive doctors. Now, when Dr. Aluya was talking about protein in the urine, microalbuminuria, he talked about using that to detect complications early detection, which both for blood pressure, hypertension issue, which is also a major cause for aneurysms, but also for diabetes affecting the kidney. And he actually used a good example of his hand, telling that it's leaking through. Now, when you detect that early and they put you on the medication to prevent that leaking from happening, you may find that, of course, you get you close that leaking, but the kidney number may get a little bit abnormal. Now, when you hear that kidney number got a little abnormal, don't go say you're going to stop that medicine just because that happened. Because if anything, you are getting more benefit from that. And it's also protecting the heart as well. Because once that kidney is leaking protein, it's actually telling us that many other organs are being affected. So please, let's do that. Now, many of us through school and even as professors, some of us still teach telling you that you cannot make an asymptomatic patient feel better. And some insurance companies operate by that dictum.
And they are wrong.
And they are wrong. You know, that just because you're asymptomatic, then you don't need anything done. That is the cause of many of those drop dead quickly, because many of the, even in the heart, what we call stage B heart failure is completely silent. And people drop dead like that. You know, so early detection, no matter how you want to try to do it, is very important, even if you have to pay for it, you know, because again, it is you, and it's your health. Thank you so much.
Thank you so very much.
Yeah.
So right. Auntie Tawa, you had your hand raised, ma. Auntie Tawa.
Hello, everyone.
Hello, ma'am. Welcome, ma'am.
How you doing?
I thank you, ma'am.
You need to do something about your throat. I had that voice. I said, oh, what's happening? The doctor needs a doctor. Yeah, my question is being answered, because actually my question is directed to you, because you said because insurance won't pay. I lost my mom. I started mammogram at 38 because of that. The insurance didn't pay, but I knew I have to do it. So I just started, I was paying on from my pocket. So some people, you just need to tell them, if they can do it, fine. If they cannot, then so be it. But I think about it like this, that this is my life. I don't care whatever money I have. If I can't spend it on me to get better, then it doesn't worth it. So I started mammogram from age 38, and now I'm still doing it. Hopefully, probably in another 3-4 years, I won't do it again. I don't even know when to stop medical something about myself. So I'll just keep on doing it. Thank you very much. Thank you, Dr. Aluya, for the wonderful presentation. You are appreciated.
You are right. You are absolutely right. People can pay out of pocket, as you know, but as far as the mammogram, there is insufficient data right now to suggest if there's benefit or lack of after 74. So from 75 up, we don't know yet if people should continue or not. So you need to continue screening till 74.
So what about pap smear?
Pap smear, the same thing with pap smear, but you and your GYN will decide that. Again, there are standards for people who have never had any abnormal pap smears that is different from people who have. Every patient is treated individually. So it's not one size fits all. That's one of the beauties of medicine practice in the US. It is individualized.
Yeah,
Thank you very much.
That one of the things again you see is, I can't overemphasize that you build a relationship with your primary care doctor, because these things really do matter. I had a patient who was brought to me by the daughter who I know, and she was 71 years old. And you know, like, hey, Mama's from Haiti. How are you? I'm good. How's everything? Good. Oh, good, good, good. So she's like, I'm bringing that because she's never seen a doctor. I'm like, why? You know, she's like, yeah, because when I see the doctor, they always find something. So I laughed and said, okay, well, hopefully we won't find anything. We did all the whole thing we did. And I looked at her. She's 71 plus, but she looks really good. She looks like almost 50 something years old. You understand? I said, Ma, you are 70, and I'm sure for the next 20 years you'll still be around. But because of that, I'll get a mammogram done for you. You've never done it. You're like, yeah, I said, we'll do it. And lo and behold, we did a mammogram, it was breast mass. Did a biopsy, it was breast cancer. So you see, eventually, when she said the reason why she doesn't come to see a doctor because they'll find something. But again, she's here, she's still alive. They did a lumpectomy, she's fine, and everything's good. So individualizing your care is the key. And the reason why most of these things, and sometimes I teach about that again, when we talk about clinical research, when a lot of all these things that were being done, we, people of color, were not considered. A lot of all these things. I mean, even the BMI that we talk about was way back in the 1960s for a 25-year-old Caucasian female. That's what the standard was. But things have moved, and we as Black people have big bones. So things like PSA, we talk about PSA, and one of those is where we talked about, cancers and screening. I talked about cancer. One of the things that we found out here is that those of us who are of African descent tend to have a higher propensity for prostate cancer. And we come in younger and they are more aggressive. But one of the things I also find out was people who are from the Caribbean tend to have a much more aggressive cancer and they come younger. So even if they say, oh, don't screen everybody until you're 50, because that's what they're saying, because, oh, there were too many biopsies, guess what? For those sequestrated portion of us who I know what they deal with, because I see it every day, I screen for PSA at age 40, period. And you see the bump, and because of that bump, we quickly repeat it in 3 months or 6 months, and then we get somebody to get sick. So these are how you tailor your care, especially if there's a family history. So it's important, get a primary doctor, develop a relationship, and then screen adequately for your health.
Thank you. So true. On point. Dr. Booker, kindly unmute. You have your hand raised.
Hello, Dr. O. Congrats on your award. Sorry about your voice. Dr. Aluya, thank you very much. I just wanted to add something. I try to encourage young people in their 20s to see a primary care physician because they wait until they're 30 and they find out there's something wrong. So I said, one, give the doctor some money quickly, she can see you. Secondly, make sure that you are normal because you may not be. Third, then I must, as I was listening, a colleague of mine ended up on dialysis because she didn't realize she had polycystic disease. So it can happen. And then she found out in her family that there is polycystic disease of the kidney. So family history is important. And another colleague of mine was exercising and he died suddenly. The wife didn't see him come up. And he had a ruptured aneurysm, ruptured thoracic aneurysm. And his father had died, had a resection done. So the brother was sent for a test and he was dissecting. So he had to have surgery. He said his brother saved him. So the family history, last thing, my sister-in-law said when she was young and she was in nursing school, she went to the gravesite in Guyana, all the families are buried in the same area. And she said, oh, this one died young. This one they all died from. Oh, they had high blood pressure. She said, really? She said, all of us. So that was the day she went straight to the doctor. The whole family plot was something to do with high blood pressure. So they were dead, but she still found out and she got the history. So that's all I wanted to add. Mm-hmm.
Wow.
Thank you.
Thank you. Thank you so much.
Aluya, thank you very much.
Wow. Madam VP, kindly unmute. Fantastic.
Thank you, Dr. O. Dr. Aluya, you said something that concerns me now, that people from Caribbean, have more history or record or data of cancer, right? Versus other people and become young. Yeah, I mean, Caribbean is where we all go and get some rest and get our R&R. So environmental, is it the food? I mean,
BP, the cancer is not floating in the water.
I don't know.
I go.
Floating. You're cutting while out. You're going to have to answer that one.
No, but I'll tell you, if you really want to narrow it down, particularly those who are Jamaican, if you narrow it down, they have and guess what? People have tried to find out why. Some people say maybe it's the ackee that they eat. They eat a lot of ackee. But some people say, okay, is it the yam? You understand? But they're not sure. And I think when we talked about cancer and screening for cancer, maybe 4 or 5 series ago, when I talked about the genetic markers that were traced all the way to West Africa in breast cancer, the same P45 gene is found in breast, is also found in those individuals with prostate cancer that results in very aggressive cancer. And that's why here now we begin to see younger and younger and younger girls coming down with breast cancer aggressive in their 30s. And I've seen it because I run a cancer institute here at the university. And it's very
we have one just passed in her 20s here in Maryland.
I think I see Dr. Popola's hand up.
That's very sad.
Yeah, but you have not answered that question.
Oh, which one?
Madam VP, the air does not cause cancer.
Oh no, I think
going to the Caribbean to go relax
Vacation.
and vacation will not cause cancer.
You're not eating the yam, so don't worry, you're good.
So like he has not, the vacationing has nothing to do with the genes. And how much food would you eat there? Even if it's
no, but again, if you want to objectively look at things, and these are some of the environmental things that we haven't talked about, where we talk about epigenetics. And one of the things that's found very high in the Caribbean is bauxite. And bauxite is huge when it comes to risk for cancer as well, especially when they mine them. But the question is, who's looking? And how many of them are paying attention to a whole lot of stuff? So we must have people who are advocates, who would eventually carry some research. If you're Jamaican or from the Caribbean, these are things that we must begin to take a look at and see why these things are happening.
Yeah, but you can vacation.
Yes, you can. I go to Jamaica every year.
Dr. Popola, kindly unmute. You're still muted. You're muted.
Thank you so very much. I was talking to myself. Congratulations, Dr. Aluya, for the usual erudite presentation. You bring out the facts from all those little things that we take for granted. And being politically and professionally correct is very important. I was moved by the question which came from Dr. Motosho in particular. He said, we must all see medicine as an instrument of social justice. And he wants this August Assembly to challenge that and let Dr. Aluya lead us in.
If you don't mind, I have not started on the chat box.
No, I'm putting my question based on that. I didn't want to repeat the question.
You can ask it. That's why you raise your hand. People who want preference raise their hands.
That's okay. So we have that to consider from my point of view, because we do put much emphasis on the protocol and procedure of hospitals and institutions. I once worked in a facility, they call it the flagship of Southern Jersey Medicine, and I was so flamboyant. We are limited in what we do in this place to just treat and let the patient go home. We are not investigating the causes of disease and illnesses. Okay, and which means we are limited. You are almost like the lawyers will say, your hands are tied in justice. Okay, whereas you know the right things to do. But where does it impact us as Black that have that disparity? We are the last people that wants to be heard. That's where I interpret such situation. In such situation, what will a practitioner do when you know that the right course of management is being denied because of so-called policies and procedures of the hospital? Personally, I had the experience when I went to UMDNJ, and security men were pulling people from the floor in the emergency room. And those hapless ladies were crying. The doctor I've not seen said, no, the doctor I've seen you through the window. He has discharged you. Until I got to a point, I thought you were going to do the same things with me. So what Dr. Aluya said, that you should introduce yourself as a doctor or as a relative of a doctor, or at least you have a family physician, is something that we must be armed with. We should tell our colleagues and friends, family, to use our name whenever they get to the hospital. It does work. I physically experienced that. They just said, the doctor has seen you through the window and he has discharged you. And they put them back out into the cold. Okay, so these are my two observations and the question that I reiterated. How do we use medicine practice as a means of getting social justice for our people and for our community? I yield, please.
Dr. Aluya.
Okay, well, yes, we see a whole lot of things that happen in the healthcare industry, especially in the indigent community, in Black and Brown communities, for a number of reasons. Most of these people who come into the ERs, when they were built, remember, most cities, the population increases. And most people are really very smart when they build hospitals. They build a hospital with a capacity ER of, let's say, 50,000 visits a month. But within 2-3 years, that capacity has grown to 70,000 visits per month for one reason or the other. Now, in the same locality, it becomes difficult to be able to handle that volume. And when people come in, the people who come in are despondent, angry. They come in, and a lot of them are repeated offenders. Pardon me for using that, but then that's because a lot of them still also.
You said we shouldn't use that word.
Have a problem with addiction as well. So and they don't have a primary care provider. They don't have health insurance, and a whole lot of other host of things. And of course, they're also victims of violence. So they use the ER as a solace, as a point of contact to the healthcare industry. So that's where often those things happen. And because of that, you see it's chaotic, and a lot of things do happen. And then over the time, it becomes a culture where if you somebody who comes in 2 weeks ago, OD, and you take care of him, and there's nothing, I mean, outside of the ER, there's no capacity for you to do. You can refer them to, what do you call it, to an addiction clinic from the ER. It's impossible. That's not your premise. And there's nobody in the ER at that point in time to do it for you, unless you admit them in the hospital. Even when you admit them, they have the right to sign an AMA, which a lot of them do. So, and then in 2 days, they're back. And they've been doing this for the last 2-3 years. So look, at the end of it all, there's fatigue that sets in, and just indolence with regards to the care of those individuals. So that's why often enough you see those things happen in those ER. But then as a tool of social justice, yes, medicine, it's a tool, and we can use that as a tool for social justice. And that's why a lot of the time you hear me say I'm a medical advocate, first and foremost, because then I advocate for the healthcare, equitable healthcare for people of my kind and my color, and those who have no access. But then we all need to put our hands together to get this done. From nursing to ophthalmology to radiology, physical therapists, we're all in this together. We have to find ways of innovative ways of finding solutions to problems. One of the things that I was exposed to recently, which I'm taking a task of doing, is, and I've seen it before, but I just didn't have the capacity to be able to do it. But somebody, introduced me, and I was shocked at what things happen. People who come out of jail often do not have access to healthcare. They just let them out, and that's it. No medication, nothing. Some of them don't have no insurance. So, and it's a process, readjusting the system. So I was invited to one of these programs that they call Returning Citizens Program. It was put up by two brothers and another guy who had spent 33 years and 30 years in jail themselves. And they went in there when they were like teenagers, and they spent that much time in jail. And they came out and found this was a problem. And they put a program where to rehabilitate and reintroduce these individuals into the society. And because I knew that that was a problem, I said, you know what, let me see how I can help so that we can, as they come out, we channel them, at least giving them healthcare, primary care, and sending them to health centers, a federal health qualified center, or whatever centers that they have. Again, because at the end, they're still human beings, and these are the things that we need to. So taking steps to advocate, seeing where the problem is, and finding solutions to it. And using innovative ways to find solutions to it is what advocacy is all about. But it stems from, you having the passion to do it, staying consistent, and being passionate about it, and seeking for results and endpoints.
Thank you. Thank you so much. Dr. Popola, the emergency room is not the place to find the root cause to problems, usually. The emergency room is a place to stabilize patients and to save lives. Somebody has a heart attack, you save them. They have a stroke, they come in within 3 hours of the stroke, you're able to reverse things. Stuff like that is what emergency room is for. Like Dr. Aluya said, it is overutilized, it is used for the wrong things. We need to educate our people on what the emergency room is used for. But Dr. Aluya, I don't know, is it in New Jersey you're talking about that returning citizens don't have health care when they return in New Jersey? Because in Maryland, when I was chief of medicine at Parkwest Health Systems, I saw this problem and I nipped it in the bud. I fought this to get the state, anyone who is returning from Maryland and is on medication, has medical problems, have a one-page sheet delineating their disease entities, their diagnosis, and the medications they're on. And not only that, they get discharged with 30 days of medications to allow them to plug into primary care. And as soon as they get out, social workers help them before they get out to get Medicaid. I still see many of them now. It's why I love my returning citizens, and I praise God for the opportunity to be able to get that enacted in Maryland. I still see some of them when they come with that one pager, I'm praising God that, oh my gosh, this is still going on. This is great. So in Maryland, that's what we do. So I don't know if you want to look into maybe doing that in New Jersey. And it was easy. It was actually dialoguing with, the medical personnel, the medical director in the prison system. It was that easy at that time, just, a 2 cents. So in the chat box, Haman wrote a lot. So Dr. Aluya, he said sometimes a bias can go against the patient in the form of cultural insensitivity, and that he agrees with primary care that his doctor is excellent and he receives pastoral care. Is fortunate because his doctor is a Nigerian also. He's in the UK and his doctor is a Nigerian, and he says he's fortunate to have the doctor that is excellent. Pastor Paul asked a question. Are providers trained to be proactive in their practice and also to be patient-centered, like it's been practiced by other professionals, to client-centered in their practice?
Yes. Well, the training initial, like everything else, medical practice and training has evolved. I did say earlier on that when we were in residence, residency back home in Nigeria, you go to work on Friday morning and you don't finish till Monday evening. And that's what it was. It was the same thing here as well. And then when I did residency, you do your overnight call, and then in the morning, the next day you're expected to be there as well. But over the course, things have changed. where you have to have at least 8 hours in between residency and overnight call or long calls and things like that. So things evolve. So also with the culture of training and practice. Um, I think about 5, 7 years ago, there was a big issue where they talked about patient-centered, care, where you coordinate the care of a patient uh, in a central form, having all the stakeholders involved in the care to ensure that this individual um, gets the best care as possible. Social worker, physical therapy, and all that. And out of it stemmed the fact that you now have health insurance companies hiring MPs or those who will now call these patients at home and say, "Hey, I want to check up on you. Have you done your mammogram? Have you done your blood work? Have you done A1C?" Some of them actually go to their houses and do the screening, including doing ABI in the leg for them in the houses. So these are some of the things that came out of these policies over time that's taking place. So even in medical education, they're also changing those modalities as well to reorientate our mindset, our doctors as well, and young doctors to think in that manner and how best to care for their patients. So that's where things are. And I think, like they always say, the only thing that's permanent in life is change and will continue to change. Technology is coming into the flow, and you're going to see policies that will eventually show that someday everybody will be mandated to wear a wristwatch or a ring that would would take your vitals, your blood pressure, or whatever. We now have the Dexcom and all that now that would monitor your sugar. We have all the rings that would. So eventually, in fact, the American Heart Association gave to hospitals blood pressure machines. I remember as CMO, I had to give those blood pressure. I'm sure that for all the centers, they give all those blood pressure machines. And once you hook it up, every time you take your blood pressure, I get the results. So it shows on the panel. I can look to see what your pressure over the years, over the months has been before you come back. So these are things that are coming and eventually will become policies down the road. So things are changing. Yes, we'll look for better ways on how to provide services for our patients.
So Pastor Paul says the cognitive bias will be minimal if they are proactive and client-centered. So I hope your question is answered, Pastor. Haman said a mass program is about to start in the UK with a deadline opt-out to have their medical records being sold by the NHS to the private sector organizations. The British government are fighting with this issue with people not working, and if their diagnosis is correct, or are people taking advantage of benefits rather than work? Do you understand what all of that means?
Yes. So here there's a network because you see, because we still have different healthcare carriers from Medicare, Medicaid. Then you have United, you have Horizon, you have all of those, including the famous Kaiser. Information is also sequestered, and that's the reason why you have a patient who comes to ERA in DC and gets a CT scan of the chest or whatever, and is not satisfied, and crosses the border into Maryland to another ER and gets another CT. You understand? Because these ERs don't speak to one another. But in the NHS, it's one central, what do you call it, healthcare system and one payer. So whatever MRI you get or CT scan you get here, by the time I order another one, I can see what's happening. So I don't have to do the CT again for you, or the stuff. But there are ways of saving money and cost and everything else. But at the same time, it allows for continuity of care, which as of yet we still do not have that much well in the United States. However, it's slowly gathering together. There's a system where everybody can log in, and those information are transferred into like a central box where all the X-ray and whatever. If I'm in this hospital, I can log in and see whatever was done with this patient somewhere else. It really does help because a lot of things are lost in translation. There are people who are supposed to be on HIV meds, and voila, they're not, because along the line it was dropped, and you'll be shocked when you talk to some of these patients. They're like, oh, well, it wasn't renewed. Or people blood pressure medicine, they're like, oh, nobody renewed it, so I just thought it was okay, I could stop. And then they come to the ER with a headache, and voila, you have a stroke. So catching these things and having a centralized healthcare system is ideal. There are pros and cons with it, but then again, the uniqueness of the United States in funding healthcare and healthcare research, again, is that the divergency that we see. But we just have to find equal grounds to or common grounds where we can give the best care for our patients.
Thank you. So it said also that in the UK, a lot of what you said about COVID-19 has been proved in the UK with deaths, with a bias to COVID and whatnot. Also, outcome bias is gathering space with AI in London. He said it's involved with law tech and medical issues so important that people of color get involved because of assumed bias that will be built.
Yes, that is huge. It's huge because, and I'll give you analogies to that. And that's why when we talk about having our people get involved in the healthcare industry, it's so huge. Look, if you have a child, they don't have to become doctors, but they can be healthcare provider in another form, in the sense that data and managing big data and clinical research is important. I'll give you a typical example. When the AI with the facial recognition first started, the design put it out there, it never put into task us as a people. And that's why when the whole thing was done, and a young, brilliant Nigerian girl was just playing with the thing in a lab, who was just put in to do what she was doing. And then for some reason, I think she walked across and the thing didn't recognize her. And she's like, what's going on here? So she looked, it didn't recognize her because it's all about coding. You have to code it in such a way that it recognizes something and it'll pick it up. So if we are not involved in this space, the healthcare disparity will continue because nobody is standing for you and I in that space. And that's why I always say, look, we need to find individuals who stand in those spaces for us and take charge and leadership in the individual spaces and finding solutions to problems that come out that are unique to you or your kind. So encouraging each and every one of us, and I tell some young doctors, I say in the future, medicine is not what will be practiced today. Doctors will have to learn how to code. Just like we now learn how to use computers, because when they turn electronic medical records on, a lot of doctors just resigned. They retired by force because they couldn't cope. You understand? So AI is coming, coding is coming. We all have to learn. And I'll tell you this, for those who are mothers and parents, teach your children code. If they're not doing it in those schools, take them to schools where they're doing it. And if they're not doing it in your county, listen, pay extra classes for them to do coding. And guess what? Grandma and grandpa, you don't have anybody you're paying school fees for anymore. Tell your children, go pay for those coding classes for them. You have to, because that's the future. You have to get them ready for the future. Like I always say one time, and I'll say this analogy this way. No matter how bad it is in the forest, the lion will never eat grass. No matter how bad the drought is in the forest, the lion will never eat grass, because that's what it does. Otherwise, it will rather die of starvation. But guess what? The cub that does not learn how to hunt will learn to hunt rats and rabbits, because guess what? He was never taught. And each and every one of us here at the lion and lionesses, we must teach our cubs how to hunt and perfectly hunt, because that's the world we're coming into.
Thank you. So Haman talked again about, big problem with screening for all communities, but that it impacted the Black community greatly during COVID. because they were encouraged not to go to the hospitals other than if they have a serious situation. Also, many routine tests and screenings were curtailed, which is now coming through after the height of COVID with bad outcomes and deaths due to delays in screening. So that's the view from Britain. And he was thanking you for the great advice you gave to follow up with primary care doctors and plan a pathway to monitoring our health journeys. He appreciates the slides and was wondering if I can get a copy. Cassandra Ewing, thank you very much. That is informative. That's our new boarding nurse, doctor, DNP. She's working on her DNP, remember? And a lot of thank yous here. Dr. Shegun Daudu appreciates and says thanks. That was an excellent talk and well analyzed. Unfortunately, he had to leave. Great job, Kemp said. Very informative. Thank you very much. So this is Dr. Omotosho's question, which you might have answered. Professor Aluya, this is a great presentation. Kudos. We must all see medicine as an instrument of social justice. The world has changed, although medicine is still playing catch up. Can you elaborate more on this, please? I think you did that, right? On social justice. And he said, do you think that doctors need a retraining in public health to be more sensitive to public health issues, to work in the Black and Brown communities?
Yes. I recently gave a talk at a graduation ceremony for young doctors and residents, as well as fellows, and those who come into medical field from the New Jersey Medical Association, which I was one time the president. Now, and I said this, that in 1940, the percentage of Black men in healthcare force was 2.6. In 2019, the percentage of Black men in the healthcare force was 2.6. Did you get that? From 1940 to 2019, same percentage. What does that mean? And the number of Blacks who were getting into training, a medical school, in 2019 was about 2.5 or 2.9. So 2022, 2023, it went up to like 3.2. So what that means is we're not having those who look like us getting into that space. And we must encourage young ones to get it, because we don't. Understanding that, like I said earlier, you're most likely to do better when you look like somebody who look like you. Now, if you don't have somebody who's representing you and advocating for you and taking care of you, then it's a perpetuation of the same disparity that we talk about, because he will never change if nobody's speaking for you. And that's just the frank beat. So each and every one of us here listening must also learn to advocate and encourage our young ones to go into medicine as well. Understanding one, there are programs that they're available that will help pay for grants and all that of people of minority. There are also schools where you can go straight from first degree into medical school without having to go through the whole process of writing LSAT. These are some of the things that are available out there so that we will know of and encourage our children. It's expensive to go to medical school, no doubt, but at the same time, we just have to. If others are doing it, then we should do it as well. So encourage one another to do it, and so that we can get the representation. Otherwise, we'll still be where we are.
Thank you. So, Dr. Emmanuel Olaketono, pastor, also said, what is the cause of cysts, either in the liver or the kidney? Some doctors claim this does not warrant any medication. Is this true? If not, what happens or what can be done?
Yeah, cyst in the kidney is just genetics. It just runs in the family for some reason, your DNA coded for it like that. And it's a process of developing in utero. Just like some people in the heart, I'm sure Dr. Zugu will know that people who have non-compaction syndrome, where the fibers of the heart are supposed to be bonded like this, because when you're in the baby, these are how the fibers are loose. But as you grow older until when you become a full-blown baby and you're born, they really stuck like this. But for some reason, for some genetics, they stuck, they don't completely bond together. It's called non-compaction syndrome. And people who have had that, the heart failure fails. It's genetics. The same thing with the liver, with the kidney, where it was just coded. Now there are different variations of it. Polycystic kidney disease of the adult, polycystic kidney disease of young children, and all that and all that. However, just knowing if there's cyst in both kidneys, discuss with your doctor, because it leads to slowly progressive end-stage renal disease that ends up in dialysis. So that's why it's important. See your doctor, make sure there's no protein in the kidney and all that. Now, I did say something earlier, I think one time, not too long ago, where we talked about, and I gave a talk here as well, kidney disease in the Black community. APOL1 gene, we talked about that, where those of us who are of African descent, especially West African descent, carry that gene mutations, G1, G2 mutation. Again, it's all genetics that puts us 3 to 4 times risk of ending up on dialysis. It's called a focal segmental glomerulosclerosis that happens to our kidneys. Now, how is it inherited? It's inherited in the same manner that sickle cell is inherited. Now, sickle cell came out of malaria because, the environment we live in has a lot of malaria, kids were dying, so we had to adjust to the malaria pandemic or epidemic. Our genes coded, position C, chromosome, 23, 20, whatever, 16, with value representing all those stuff that resulted in sickle cell. With this one, what has happened, the same genetic modification is out of what they call it, the African trypanosomiasis, the sickle sleeping sickness. And that's why it's predominantly those who have West African descent that carry that gene that happens here. And that's the reason why most people who came from West Africa, who brought in from slaves, came from West Africa. So they carry that same gene. Studies have shown that 15% of Blacks in this country carry that gene. But how many of them know? They don't know that. Screening early for protein in the urine would help you catch those things, put you on medication, so you'll be aware and preserving your kidneys.
Thank you so much. And talking of that, I didn't want to read it verbatim, but Herman was saying that in the UK, Black men have the highest rate of prostate cancer in the UK. And you did mention that. You mentioned Black men and then, and also Caribbean.
Well, guess where those Black men in the UK are from? Guess where?
The Caribbean? No.
Okay. You and I know that.
Yeah, we do. So, Pastor Paul said, could this be another factor of institutionalized restriction to encouraging or pre-qualify minority-focused interest in medicine as made available to non-minority population? Pastor Paul, I think you need to unmute and ask your question, please, to make it better.
Yeah. Thank you, man.
Thank you. Thank you so much, sir.
So, I appreciate the opportunity, man. Dr. Aluya, great presentation. Aluya, very great presentation, I have to say. But when you were actually attempting to answer my previous question regarding the centered therapy, which is practiced in the social science field, this client-centered therapy is actually focused on the patient or on the client. It does not include or incorporate any other people in that kind of focus in terms of the therapy or consultation that a patient has with the physician. It is only focused on that particular patient, whereby the doctor takes into account whatever that patient brings to the table, so that the doctor is in a better position to acknowledge the fact that this patient also should have an input into the diagnosis. That is what I meant by the focus therapy or patient therapy. And which means it does not necessarily incorporate or bring about any other family members. It's just exclusively focused on that particular patient. So in the context of the other issue that you brought up, that brings about the very minimal number of percentage of minority in the medical field. So in a way that I did not want to use institutionalized racism. So that's why, yes, and that's why I brought up the other issue of saying, is this something that is making it impossible for the Black men to be in that field of medicine? That's my question. Thank you, sir.
Yeah, so you can say yes and no, but categorically no. And I'll tell you why. There's a whole lot of things that happen in this country, and we can't obviate from the fact that there's a systemic, definite, deliberate act to destroy the Black family, period. You take away the man, the whole family is done. And that's why in most Black homes, there are no men. I mean, if you look at the statistics in this country, in homes where, in fact, I think 45% of homes are led by women. And in homes where there's a husband and wife, 45% of them are women who are the primary breadwinner. Again, data is important. And that's why you find that that systematic decimation of the Black home has resulted in a lot of things where you don't have the men that choose children to look up to. You cannot be what you don't see or know, period. If in that community, all they see people coming out basketball, playing soccer, carrying guns and shooting and doing drugs, that's what they aspire to be. A lot of them never seen somebody who's gone to medical school. They've never seen that. How would they aspire to be that? So it's a process that was put in place, but we're riding that process, and these are the outcomes. So that's why in the Black and brown community, you don't see these things happening. Where there's mass incarceration, people decide to build the number of jail based on the pass rate at the 4th grade level. I mean, these are institutionalized things that the outcome is what we see, that we don't have people who represent us at places. But thank God for immigration. Again, that's why there's a whole lot of restriction in those numbers. So that when these guys come in, the people who are coming and immigrating here, educated, highly motivated, and pissed off at a whole lot of system, that their children eventually end up pursuing academic prowess. And I, at the university where I was, and I told them, I said, listen, I'm here and I'm standing for you. Because if I'm not here, the person who is standing in front of you will not look like me. So my role is to be what I need to be and raise as many people as I can. And that's just the way it is. So it's the impetus is on us now to come together and see how we can solve our problems. It is a problem, and rebuilding the family structure again.
Thank you, sir.
Thank you. Thank you so much, Pastor. Is your question answered?
Yes, sir. Yes, ma'am. Thank you, ma'am.
Thank you. Our darling sister, Mary Adebowale, kindly unmute.
Hello, everyone.
Good evening. Welcome, Miss Virginia.
Oh, my goodness. Okay, so thank you, Dr. Aluya. So I just want to mention a little bit of some of the things that have been given as excuses for maybe men, especially not doing colonoscopy, because I had a patient today and he told me a story about 2 or 3 of his friends that died from colon cancer. And what he said specifically, and I've heard from different men, is they, especially black men, they, I don't know what's in their mind, but I think they attribute having a colonoscopy to fondling with the anus. So, and this is not the first time I've heard that. Like, oh, nobody's touching that. I'm not doing it. So he specifically told me that some of his friends, when he told them that you guys were supposed to have this thing, but after they decided to do it, or when they got sick, it was too late and they all died. So this was just today. And I think it was an assignment that I did in the state of Virginia, a black man, I think number 1 for colon cancer. So, and that has not changed. So one thing I have decided to do is try to educate, okay, as much as I can. And I always just tell them, oh, you're going to be asleep for this. And so some don't even want to do a feet DNA. I had a lady, she's like, oh no, I'm not doing it because my brother, he found out he had cancer and he died. And my mother, so she had a family history of different cancers. And I had to, like, I spent a lot of time with her though. And I told her, you really do want to find out about this? And your story might be different from every other member of your family. And I tried to make her understand that your family told you, oh, they had this and they died. Or you found out they had it and they died. Did you know what they actually did and how long it took them? Or did they follow up on some of the things that were in between all the things that you were telling me? I think I was able to kind of win her over a little bit. And I think she did it because I saw on my chart that she did. So I was able to convince her to do that feet DNA test. So on another end, I was you were saying something about black um black people going to medical school. I do have this conversation as well. Not only medical school, but trying to do better when it comes to every other thing in the United States as black people. And my opinion is there are not a lot of mentors because if and information for this set of people, my opinion, and most of the people that I've had a conversation with, like if you have people that have done this maybe in your family, then you have a better chance of maybe following their path, or you have a community, not and you might be able to follow about whatever example you've seen in your community. So we do have a lot of guns and violence in some communities, and that is what a lot of black people see, and that's what they follow in their own community. So how do we go from here? What are we gonna do? And what are the things that we want to put in place to assist to move our race forward? Because I know we need it. And I pray we try to figure it out soon so that everyone can achieve their best in life. Thank you.
Yes, thank you. With regards to men not wanting to do colonoscopy, and you saying, what they say, and ain't nothing going up there. Look, there's a history behind it, and sometimes we tend to forget some of the things that happened to the black man. Um, the black man, not to sugarcoat anything, were deliberately raped in this country in front of their families just to denigrate them. And there's history with those things. And this has gone on in perpetuation. But sometimes, things get lost in translation, and to the point that people forget. And that's why those are the things, the reason why we get so uh, 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 spewed when it comes to things like that. And if you understand, again, the history, how many of us were doctors at that point in time as well, all through history, to allow people who are not like me to stick something up again in the rear when I'd known what they did to my grandpa, my grandma, all that. So that's where the history is coming from. So it's not arbitrary. It's not from space. No, there's a reason. Because if you know these things, then you'll be able to understand and sympathize with us and know that above all, we've had some progress. Do we have a lot of work to go? Yes, we do have to. And that's why for somebody like you and me and all those who are in the medical field, our work, it's a lot. I'll say this, there's a whole lot of harvest to be done, but the workers are very few. So you may have to do far more. And I'm glad you did what you did to convince that woman to get it done, to get the fit test done. I had a guy who took me 3 years to convince me to get colonoscopy. But you know what? I did that because we didn't have options then. There was no fecal occult, no Cologuard. We didn't have any, So, and when he did it, he came and brought his wife. I said, Dr. Aluya, I must see you. I said, why? He said, after God is you. I said, why? He said, because to save my life. When I did it, eventually, because I told him, I said, listen, as long as you keep coming to see me, I will continue to ensure that you get that colonoscopy. You're like, yeah, to get you off my head, I'll just go get that done. And I explained to him how easy it is. If you're going to do colonoscopy on Monday, from Friday, stop eating heavy. You understand? Start eating lighter and lighter so that by the time on Sunday you start drinking that stuff, you don't have to go to the bathroom multiple times. And it's a lot easier and it's cleaner. You understand? So that's how I explain to patients. He got it, and guess what? Voila, they found stuff. But he's alive today. He's still doing well. So that's how much effort we may have to. Because once you win one, that is a medal to you that you're going to hold and say, you know what, I did this. So that's where we're coming from. In terms of healthcare and people in the medical practice, look, some of you see that I belong to a group called the Physician Health Network. There's a bunch of Black men, 12 of us from different subspecialty who come to give talks every time. And we used to go from city to city, school to school. Again, when it comes to career day, look, call your groups in your locality. Call your doctors, the MPs or whatever. Beg one of these doctors, come with me. They'll come. Give them an adequate time and they'll come. And if they can't, listen, if you have an NGO, put it as time spent for NGO so that you get credit for that, for his NGO. You understand? You can. They can write it off for taxes. So that when you go to those schools, especially inner cities classes, and you speak to those people so that they see that there's Black men and women who are doctors because they've never seen one. And then they will aspire to be one. I'll tell you this, I aspired to become a doctor today because I saw my uncle at age 4 who was a doctor. And I said, who's that? They said, oh, it's your uncle. I'm like, what does he do? Because I like the way he looked. He says he's a doctor. I'm like, oh, I'm going to be one too at age 4. And that's where things happen. So we must find ways of putting things together, looking at the resources that are around you so that you can get work done.
Dr. Aluya, thank you so much. That was deep. And in conjunction with that, Dr. Akitonde said, there's a need for more male mentoring groups for the Nigerian American males. You're right. We have our work cut out for us. We all have experienced this. We have to keep at it. And that makes your presentation tonight so on point and so timely, because as healthcare professionals, it doesn't matter what type of work you do in the healthcare arena, we need to be empathetic, and we need to be patient and meet our patients where they are, not labeling them, but just meeting them where they are, educating them, and making sure that they get the needful done. So before we conclude, I just want to share that Nigerian Center did amazing for us this last weekend. They represented Nigerian Embassy at the Passport Day. There were over 60 countries represented, countries all over the world. This is done by the US government, I believe. But Nigeria, they take last. How do you say it, Dr. Aluya? Help me say it.
Carry last.
Nigeria, they carry last.
Nigeria, carry last. Believe it or not. Nigeria was branded the best country, produced, a band, one of our best, Toyosi, was the one that went, live band, Nigerian band, Nigerian jollof rice, food, and the 4 caterers that went, their food finished. It was amazing. They had Nigerian arts, fashion. We had the Igbo group actually did cultural dancing, and they said Nigeria was the best. So we did fantastic, but some of the vendors still need to be paid. Nigerian Center needs to be, assisted financially. Please, Dr. Veronica, thank you. I forgot for posting.
I know you forgot, so I wanted to make sure, because our community likes the support, so there.
So if you can support, please support. Dr. Veronica, if you can post it, it's in the chat box.
It's in the chat box, yeah.
That would be great. Nigeria know they carry last too. We did fantastic.
It has the email Zelle address. It's an email, info@Nigeria House. It's there on the chat box. Please, if you copy it and just Zelle whatever you can, $50, $100, $5,000, we'll take it. Anything. Thank you so much for helping.
Thank you.
Mr. Gucci is doing a fabulous job. All we need to do is support with whatever we can. Thank you. And thank you, Dr. O, for all the help you gave Nigeria House to make it successful.
Thank you. Thank you so much. Thank you for all you do. Thank you. And she had donated. She was the first one to donate. You see,
and you too, Dr. O. So yeah, so it's not too late. They need to pay a lot of settled bills. So please, it's a community event, it's volunteerism, and it's also tax deductible because it's a 501c3 organization. You'll get an email immediately acknowledging your donation, and you can use it for your tax return. Yep. Thank you.
Thank you. Thank you so much. God bless you.
Amen. God bless you too.
Our brain. Thank you so much for the amazing presentation. Please give us your parting words, what you want us to take home. Gidigongo tonight, please.
Thank you, Dr. Aluya.
Well, thank you once again for the opportunity. It's always a pleasure to come here and talk and have frank talk to engage our community, inform, educate each and every one of us. And like with the title today is empowering the patient and helping to reduce healthcare disparity. As individual, irrespective of where you're from, how you're from, whatever, as long as you're Black, you're still an African. That's one. Two, you'll still be looked at differently, and they don't care whether you're Nigerian, Jamaican, American born, you're Black, and that's how you're looked at. So we must come together and addressing our common problem. We do have them numerous. It starts with the family, building our family together, and ensuring that as we build the family up, we also build our communities. Get engaged, be involved in community activities. Not one person can make a forest. Together, we will make that big protected forest. And as we do that, encourage one another as well, because there's so much going on around us in our community. And we need to help and show that to lean on. But on a parting message to you individual, get a primary care physician, the one who most likely will look like you if you can, or anybody who you think you feel and you jive with and understand where you're coming from. Because even other people from other races do understand and they advocate for you as well. Find out who that person is. If you're not comfortable with your private care, look for another one and seek people who know people who know people. And that's how it goes. So that build a relationship with that individual and ask questions. But do your research as well. And when you're in doubt, ask questions. You have Dr. O here, reach out a message. You can reach me anytime as well. We're available. That's what we're here. At the end of it all, two things I always say. There's the politics in everything, even the politics of healthcare. We see what's happening with the disparity, and there's the economics of it as well. Politics and economics are the yin yang of human existence. You have to get involved in one way or the other in that flow. That's why we're here at NAPAC. Even we're trying to put the political aspect of things into economic outcomes so that we can truly protect our community and advance our community. Thank you, and God bless.
Thank you, Dr. Aluya. Thank you so much. God bless you. But it's election year. Encourage us to go to napacusa.org, register as members so we can together, get our candidates into office.
Yeah, representation matters.
NAPAC, napacusa.org. Thank you so much. God bless you. Till we meet again next week, everyone, please keep safe and stay away from, don't be like me. Because there are still bugs out there. Okay. Stay safe and stay healthy. Love you all.
All right. Good night, everybody.
Bye.
Love you too. Good night.